set my little timer. Okay. Well, hello. My name is Kimberly Parker. I'm so grateful to be here with y'all today. I'm going to be talking about one of my favorite topics. I'm going to try to reel myself in. I normally do presentations for 3 to 4 hours. So 20 minutes, I'm really having to show restraint, but it's also teaching me a skill to be concise. So today I'm going to be talking about decolonizing mental health when standard models miss the mark. All right, so to just tell you a little bit about myself, again, my name is Kimberly Parker. I am the CEO of Revive to Thrive Wellness Center, which is a counseling center in the state of Texas. I work with a lot of cycle breakers. I'm basically my client, an individual who values collectivism, but they're also working to be their best and highest selves. So they want to keep their family members and other folks that might have some dysfunction still, right? But they also want to be their best and highest selves. And so that's my counseling practice. I'm also the founder of the Healthcare Green Book, which is a directory that helps connect individuals from marginalized background to culturally affirming therapists that have been vetted and trained. In addition to that, I'm a clinical supervisor. I have counseling associates in the state of Texas working towards full licensure. A trainer and consultant. I love this topic of cultural humility. Again, I'm going to keep myself, as well, I'm going to just let it all out and then just, let it all out in 20 minutes. And then in addition to that, I'm also a doctoral student. I'm in my 5th and hopefully final year of my doctoral program. I'm looking at the lived experiences of individuals. Again, I'm looking at someone like me who decided to just decolonize their therapy practice. And I want to look at what does that professional journey look like, as well as the interventions that they're utilizing in their decolonial work. Personally, I'm a Black woman. I'm an auntie, which is my favorite job. We have 3 teenagers right now, and it's just so overwhelming. But exciting. My nephew has a girlfriend, so it's just going way too far at this point, y'all. And a sister, a daughter, a friend. I'm a concert goer. I look forward to seeing Olivia Dean in a couple months. And an NYC lover. I'll be back. I know. I'll be back next month. And overall, just someone who really cares for others, And that's what brought me to this work, and that's what brings me to this decolonial work, because I want folks to get the help that they need and deserve. So thank you for having me here today, and thank you for being here. I know you've had a long day, so thank you so much. So today I have 3 objectives that I'm going to go over, okay? The first one is identify ways Eurocentric mental health models can misinterpret or pathologize women's distress, particularly for BIPOC women, okay? In addition to that, I'm going to also talk about how cultural misattunement contributes to misdiagnosis, early dropout, and mistrust in mental health care. And last but not least, I'm going to give you 3 practical, culturally responsive shifts, also decolonial shifts, to assessment, intervention, and conceptualization that can be implemented in your clinical setting. And just curious, how many clinicians do we have in the room? Awesome. Researchers, students. Awesome. Who else? I always love to know who's in the room. Educator. Amazing. All right, so I always love to start my presentations off with a why, and so especially as it relates to this topic. And so for this example, I want to talk about a Black woman, but I always say that every Black woman was a Black little girl, right? And so with this particular client, she was someone who aced all of her tests but did not do her homework. Because of that, she had folks saying things like, "You're lazy if you just applied yourself, and you're really smart, but," and this led to my client thinking very, very negatively about herself, very down on herself, believing that she is lazy, when really it was what was going unexamined in her life: culture, history, relationships, and systems. And so that led to questions like, what's wrong with her instead of what's happening to her? And for this client in particular, what was going on was she was a little parent. Her mom was a single parent, and she was the one who did homework with the kiddos and made dinner with the kiddos and just took care of them like she, again, was their parent. And so how would she have time for homework? But again, she was acing all of her tests. And so in our work together as an adult, we've been working to create more balanced and compassionate beliefs. But there's also been a lot of resentment and anger towards how her experience was being misread. And so that's just one case study for today. So before we get into how dominant frameworks misread distress, I thought it would be helpful just to recap what our dominant frameworks are. And so this is my favorite thing to talk about ever, is the 5 forces of counseling. And it says 5 forces of counseling, but really, we also had psychologists involved, marriage family therapists, social workers, so on and so forth. And so the dominant frameworks are going to be the first 3 forces, which are psychoanalytic. I'm thinking about Freud and Koch right now. I don't know why my mind just went there, but that was my initial thought. Cognitive behavioral, Dr. Beck, and any humanistic or existential theory would be in the 4th force. We have our 4th force and our 5th force because essentially what occurred is that it was noticed by Sue and colleagues in this task force that they put together, again, it was a collective effort, that the first 3 forces had two main critiques. And those critiques were they did not consider socio-political context, and they also didn't consider culture. And so with the world becoming more and more of a melting pot and experiencing life events like the civil rights movement, we had some really, really amazing people who said, hey, there's a lot going on in this world right now. We need to make therapy multicultural. Okay, and so leading off from that, we have Ratz and colleagues who created the multicultural social justice counseling competencies, such a tongue twister. But essentially what they did was, I like to say they added the advocacy to the MCCs. And so the MCCs, they call for us to look into our biases and assumptions. What's the knowledge that we're obtaining to become more multicultural, as well as the skills that we're utilizing and the action that we're taking. With the MSJCCs, they took it a bit further by considering identity as well as intersectionality, because we know when an individual has multiple marginalized identities, those start to compound and that becomes an issue, right? That makes those pain points even more severe, and we're going to talk about that a bit more. And so, again, just wanted to kind of lay the foundation for what those dominant frameworks are that we're talking about here today and how they miss the mark. And so, so sorry. Okay. Yes. Intermission. So sorry, y'all. Thank you. Okay. Thank you so much. All right. Intermission over. Okay. So going back to those dominant frameworks, and thank y'all so much. I just love all the pink and all the warm faces. And so thank you so much. Pink's my favorite color. And so going back to those dominant frameworks and how they miss the mark, distress is often framed as an individual deficit. And so you might hear an example like it's her versus the world that she lives in, which is problematic. Additionally, sociopolitical and environmental factors can be minimized. And so this might be like asking a trans woman to examine her cognitive distortions about the microaggression she's experiencing at work, which again, we know is a big no-no. We absolutely are not going to do that, but that would be an example of that. In addition to that, we know that Western norms about coping and functioning can be treated as universal. So when we think about grief, I kept wondering as I was going through my own grief, why do I feel like I just have to get over this, one of the biggest losses in my life? Because you get 3 days off and then you need to get back to work and put a smile on your face and act like everything's okay. And again, that's just a norm based on the world that we live in. A few more examples about how the dominant frameworks, and again, this world that we live in, very individualized world that we live in, miss the mark. And so, for example, when it comes to trauma, an example might be a woman, and I was just talking to Judith about this, a woman who stays hyper-aware and guarded after repeated harm is labeled anxious instead of being understood as protecting herself. Or for grief, a woman who continues caregiving and just pushes through after loss is seen as avoidant rather than carrying responsibility while grieving, which many of folks have to do. For oppression, a woman expressing anger about racism is labeled aggressive. I don't know how many times we've heard that, instead of being recognized as responding to ongoing harm. And lastly, for caregiving roles, a woman who puts other needs first and feels exhausted is praised for being that strong woman, that superwoman schema. Oh, you just have it all together. When really she needs to be supported in the burnout that she's experiencing. And I'm going to tell you, I'm sure you may know someone from these examples. I had faces come into my mind as I was sharing these examples because, again, this world that we live in and how it fosters these beliefs and these experiences. And so the consequences include misdiagnosis, disengagement, and client mistrust. And so for BIPOC clients specifically, clients can experience, and clients in general, but speaking on BIPOC clients, they may experience overdiagnosis and underdiagnosis. I don't know how many folks who said, hey, I was hearing from my ancestors and now I'm being told that I have psychosis. Right? And so what's going on there, or even the client that I mentioned to you at the beginning, the case study, she was diagnosed also with ADHD. Again, super brilliant mind, but she just needed some TLC and for someone to read her situation for what it really was. Because of this, some people leave therapy early or it goes underutilized. I know me personally, I dropped out of therapy years ago prematurely because my therapist, who was a brown woman, and I say that because no one is immune to cultural ruptures, including myself. She told me to go home and set boundaries with my black mama. And personally, I choose to see the next day. And so I don't know if y'all ever met a black mama before, but personally, while I love and adore Lisa Parker, my therapist wasn't wrong, but she just was taking me a little too fast. I needed a little bit of compassion, a little bit of TLC, and I didn't go back. Because I wasn't assertive at that time to tell her, hey, we need to talk through this cultural rupture. And that's what we know, many folks won't go back. Microaggressions, of course, reduce trust and worsens outcomes. And what happens when individuals stay sick? Their community stays sick and they don't get the help that they need, which of course is extremely problematic. Why this especially matters for BIPOC women is because, again, going back to that concept we were talking about with intersectionality and how that compounds the pain points, and that's what I love about the fifth force in counseling by Ratz and colleagues is that they added that intersectionality and identity aspect to their framework. Once before I had someone, they were making a joke. You know how sometimes we can deflect with humor, and they said, well, I'm black and gay. And I knew exactly what they meant by that they had two marginalized identities that impact their world, that impact their worldview, and that was just a little too much. And you can only think about what else we could add on there, right? That would compound that even more. And so clinicians at times can miss the mark as it relates to identity as well as structural harm, again, in this work with BIPOC women, and forgetting the aspect of systems as well as intersectionality. And as it relates to cultural misattunement, again, going back to the microaggressions, the subtle discrimination that takes place in counseling. I'm going to tell you this, I didn't know if I was going to mention this today because it literally just happened, but I've been working with my therapist because as a therapist, I love, having my own therapist. And we actually had a cultural rupture on Monday. She doesn't know it yet, but I'm going to talk to her about it. Okay, I'm going to talk to her about it. And because I did some research with my other people and they're like, no, Kim, you didn't make that up. And so, but I feel safe enough to do that. And so it also goes to show you that safety can go a long way in this work. Clients, when these types of things happen, the microaggressions, the macroaggressions, the racism, the isms, if you will, clients report discomfort, stereotyping, and even their therapists imposing their own values on them, which again is problematic. This misattunement can also, this one is so big, can lead to clients not bringing up issues about race. And I'll tell you too, I'm very vulnerable in my trainings. That's just how I work best, or my presentations, is that I actually have two therapists because one specializes, she's a white woman, she specializes in one thing. But I also really felt that based on what's going on in this world, I needed a Black therapist as well. There's just some things that I need to tell her that go unspoken that I need to say out loud. She gets it, and it works. And so I have found a way to kind of make this work for me by seeing who I need to see and getting my needs met. But we know, based on the statistics, cross-cultural relationships are inevitable. So I always say, why not get prepared for them? I also like to mention that if cultural ruptures are inevitable, then maybe, just maybe, cultural repair can also be inevitable. And so moving forward, I want to talk more about utilizing cultural responsiveness and decolonial frameworks to shift care, again, when we're working with folks so that we don't misread their symptoms and what they're experiencing. And I thought I would just kind of start us off with a quote, and I really wish I would have replaced this with Dr. Mullen. She looks very cool, and she's an awesome person. But this is a quote from her book, Decolonizing Therapy. She's done so much work on this and has been such a great leader in the field. And it says, more than just independence from a colony or colonial power, decolonization has become the process by which we heal the society, systems, and political frameworks we live within so that we may achieve true healing for our communities and selves. It's a return to ancestral wisdom. So again, just kind of like to lay that foundation. Some folks ask me like, well, what is decolonization? I like to say it in short, like, well, in order to be decolonized, we once were colonized. And so we take it back to our ancestral roots, right? Yeah. Absolutely. And so what decolonizing therapy adds is, again, returning back to ancestral wisdom, those things that maybe we were told were bad or witchy or, oh, don't do this, right? And our collectivistic values, because we are stronger together, and there's so many of us who value collectivism and community. I know community personally, again, with the world being on fire, with having one of the biggest losses of my life to date, community has saved me. And so it's so healing, right? It also recenters lived experience, intergenerational trauma, and community authority. Again, with some of those dominant frameworks, I'll go with CBT, and I used to be a hardcore CBTer myself, and I still pull from some tenets of CBT, and no diss to any CBTers here, but sometimes it might be more present focused. Well, what happens if we're missing everything that's going on in the past? You know, personally, when my clients come into the counseling room, I see their mothers, their grandmothers, their grandfathers, and everyone who came before them. And then the trauma ran into them, and they said, I don't want to proceed with that. I want to do something different. I want to live different. It also examines and deconstructs the historical foundations of the field. Personally, I started in this field 20 years ago, or working towards this field 20 years ago. And to go through this deconstruction process, when I think about the time and the money, I'm going to say that again, the money that was spent. I'm still waiting to hit the lotto, y'all. And also the harm that I have done to clients because of what I didn't know. I think about all those things, and it's been such a reckoning. It's been such a reckoning. And so those are some of the gifts that decolonization work gives us. Some assumptions that we might have worth challenging when doing this work would be, what even gets labeled healthy coping? And what gets labeled dysregulation versus survival? Or another word I like to use is adaptation, you know? Whose norms define insight, resilience, and recovery? So I want to give you all some practical shifts. I'm going to look at my timer. I'm just about running out of time. Practical shifts for utilizing this work, again, being more culturally responsive in this work that we do, is change the assessment lens. And a couple of things that you can do for that is ask about context. What are those external factors that are going on? Include identity, systems, stressors, and survival demands, as well as use language that clients can understand. I know we have all of our clinical jargon and all that good stuff, right? But we can put some of that aside. Another practical shift would be to change the case conceptualization. So looking beyond just the symptoms and what's going on individually, and considering again what's going on with the system, what is going on with external factors. include trauma, oppression, history, and embodiment, and conceptualize distress as relational, structural, and cultural, not that this is just the individual's issue or a moral failing of the individual. One last shift for y'all is to change what happens in the room. You can do this by reducing power differentials, so that looks like broaching conversations. I like to say that broaching can happen even before that very first counseling session. It can be what's on your website, what is in your intake paperwork, so on and so forth. What does the artwork look like in your office? Is it representative, is it representing the various clients that you meet with? Additionally, you want to use collaboration and transparent language, but also language that I would say is less, we hear words like maladaptive, so on and so forth. And so, again, being someone who still pulls from CBT, an example I use is maybe this thought is unhelpful versus it being a negative thought or a negative cognition. And we also want to make room for spirituality, community, ancestry, and collective healing. We won't have time to go over this slide today, and I knew we wouldn't, but I still wanted to give you this nugget. I like to pull from 3 frameworks for decolonial work. Dr. Jennifer Mullen, of course, but the feedback that I get about her framework is that at times it can feel really heavy, and it is, and that's not even a negative critique. It's just it can be really heavy and at times even feel a bit abstract. I also like to pull from, and I hope I'm pronouncing this correctly, Adamus and colleagues like Chavez Duenas, one of my favorites, both of my favorites actually. They're keynoting at APA this year. I don't know if anyone's interested, but they have a wonderful framework, and it appears to me to be more like a step work, very tangible. But then we also have this framework, and this was specifically created for BIPOC communities by Dr. Sadi, and it is comprised of 4 different ideologies, including trauma-informed care, anti-racism, anti-oppression, and culturally responsive. And she doesn't have this diagram exactly in her book, but I pretty much extracted them from that to kind of give you a visual, including some tangible skills that you might use. So what this can lead to is better attunement, can lead to reducing rupture. And what happens when we have less ruptures? Clients can stay in care and they can get the help that they need. All right. So I have some questions here for y'all to think about. Where might you be over individualizing distress? Or maybe it's been an experience that you've had. What structural or systemic realities might you be missing? And what is one shift that you might make moving forward to offer more culturally affirming and decolonial care? And I have a QR code here just in case anyone, we'll see if it comes up actually. I may have skipped it. Okay, there we go. I have a QR code there in case anyone wants to stay in touch or has any questions or thoughts. And again, thank you. What is today? Today's a Saturday. It's the end of your day. Thank you so much for spending time with me and learning more about this topic or expanding on your knowledge on this topic. Thank you. Thank you so much. Thank you.